Welcome on behalf of the International Cardio-Oncology Society. I am Dr. Tom Murtaugh of the Christ Hospital in Cincinnati, Ohio. Today, ICOS would like to present highlights from a recent webinar on BTK inhibitors and cardiac complications. Our main presenter is Dr. Jeff Sharman. Dr. Sharman practices in Eugene, Oregon, where he's the Director of Research at the Willamette Valley Cancer Center. He also serves as the Medical Director for Hematology Research for the US Oncology Network. Today's excerpts will focus on hypertension related to BTK inhibitors as well as arrhythmias. Please enjoy today's highlights.
So next I'll move on to hypertension, and the CTCAE criteria for hypertension are shown here. Really, the key distinction here is that in grade 2, you might be changing baseline cardiac meds, and in grade 3, you're typically looking at multiple drugs for the control of hypertension. Grade 4, of course, is life-threatening, oftentimes with end organ damage. Grade 5 is a significant problem. This shows hypertension as a product of time for ibrutinib, with systolic pressures on the left and diastolic pressures on the right. And by 6 months, patients may see about a 5 to 20 point rise in their systolic blood pressure, but eventually this kind of appears to plateau. Unfortunately, in oncology, I would say we're often happy if a patient shows up and they're not in a wheelchair. So I don't think that the oncologist's sensitivity to hypertension for these drugs is nearly as acute as might be customary in a cardiology setting. And the hypertensive effect is probably unknown by most general oncologists. So CLL specialists are certainly aware of it, but most CLL patients are not taken care of by CLL specialists. And I would say it's a side effect that many general oncologists are unaware of. And it's a relatively subtle effect in a group of patients that are perhaps not seemingly as urgent as many as the other solid tumor patients. And so, it kind of creeps up on both patients and the physicians taking care of them. And I think that as a cardiologist, it's something that you can help manage, because I don't think that oncologists are necessarily providing the level of antihypertensive management for patients who are on ibrutinib. So to summarize hypertension, I would say that the pressure increases slowly over time and may not be addressed by the general medical oncologist. As recognition has grown over time, patients already requiring 3 drugs for hypertension are now being excluded from many of the ibrutinib studies. And as we'll see next, the effects on hypertension may not be uniform within the drug class, and alternative agents may be useful for the hypertensive CLL patient. So next we'll move on to the discussion of arrhythmias. Overall rates of atrial fibrillation. Yeah.
Sorry again.
Yeah, please. No, go for it.
You got some good mojo there, but so because I think that we're going to get into as you talk about arrhythmia, we're going to get into bigger ponds here. But if you just talk about bleeding and hypertension, which is what you've covered so far, the bleeding, the part that you emphasized about holding during, upcoming procedure, I'm not sure that cardiology as a general rule understand that. I know certain cardiologists may, but across the board, I would just speak for them saying, unless they happen to look it up, most patients that are on ibrutinib or other BTK inhibitor, that doesn't really register on the cardiology front. So the whole idea about somebody comes in with concern about an acute coronary syndrome and they're going to go to the cath lab and they're on ibrutinib or other BTK inhibitor, they definitely need to take a step back and hold off if the patient can be stabilized then they need to, give it some time to get out of the system, because they're going to get very potent antiplatelet agents. So just that single piece is not very prevalent in the cardiology world, in my estimation. But Joe, what would you say about that?
Yeah, so, I don't know the right answer. I know it, you know it. I'm not sure that the rest of my colleagues know it either, but I think for the most part.
But you're generally speaking, I hope you're not hanging out in the emergency room when somebody comes in with chest discomfort and, they're going to go to the cath lab. That's, I hope at this point in your life, you're not doing that. But I think the rest of cardiology who's seeing a patient in the emergency room who happens to be on ibrutinib or some other drug, then, they probably don't realize that they need to take a step back for a few days if they can.
Well, yeah, if the oncologists drum this into the patients, and the patients know that if they have anything, that they have to hold the medication. So more often than not, when I tell them, hey, you have to hold your drug for 3 days, they say, I already know, Dr. So-and-so told me that already. So I don't want to throw it on the oncologist, but it really is, I think, part of the responsibility of oncology to do that, was if you don't have a relationship with a cardiologist and you have an acute issue, you're likely not to find somebody who understands that concept.
I think that there's always we all have to sort of be thoughtful about risks and benefits and so forth. I think if somebody's got an ST elevation MI, you're going to replace the blood or replace the platelets or whatever you have to do if there's a bleeding complication. I think if you have an elective TAVR or Watchman procedure, that might be a spot where you have a little more control to withhold BTK inhibitor. And I'll just say from an oncology perspective, a couple things to be aware of. Drug withholding of BTK inhibitors can be very different to patients at different points of their disease. So if somebody is sort of recently on a BTK inhibitor for the first time, BTK inhibitors cause a migration of cells out of the lymph nodes, bone marrow, and spleen into the peripheral blood. And then, so paradoxically, we see patients' white blood cell count shoot up when we start a BTK inhibitor. And then when you hold the BTK inhibitor, it goes back down too. Now, over time, the cells come down and the lymph nodes stay down as the cells die. But there's a very dramatic, we see patients whose white counts are 20,000 go up to 250,000. Those are numbers that aren't shocking in CLL. They're always impressive to see, but not shocking. And patients will sometimes complain of discomfort in their lymph nodes if they stop a BTK inhibitor early on. If their disease is well controlled, starting and stopping a BTK inhibitor is not that much of an issue. But the really dangerous patient is the one who's already starting to progress on a BTK inhibitor. If you hold that patient's BTK inhibitor, they will oftentimes, about 3 days later, really get into a cytokine situation that can be pretty ugly. Fevers, tachycardia, discomfort, they almost look a little bit septic. And so knowing where a patient is in their disease is important as you consider a drug hold. And of course, from a cardiology perspective, sometimes you don't have the luxury of holding. If myocardium's dying, then you're just going to have to do your procedure and we'll, it's like the patient took an aspirin that morning and you have to do your procedure. Sometimes it just happens, right? So
yeah, I think
I will jump in.
I think that,
go ahead. Yeah,
your whole conversation right there was really perfect. That is so true. And if we're dealing with an acute coronary syndrome, we're going to do what we need to do. But I would say, at least my general impression, the potent effect of ibrutinib or its partners is similar to a drug that would be in between aspirin and Plavix. So it's more potent than aspirin, probably less potent than Plavix. And so going into an intervention, you probably need to keep that in mind. But then the last piece that I did want to bring up about hypertension, because this hypertension is the number one risk factor for the development of AFib. And in an older patient population, the one thing you want to do is control hypertension in order to prevent the development or recurrence of atrial fibrillation. So this is a proactive point that we should be cardio-oncology should certainly be proactive on this issue. So hopefully that segues you into your next topic. So
perfect. Yeah, thank you. So overall, the rates of atrial fibrillation in the early studies came out to around 10 to 15% with ibrutinib. And since initial approvals were based on non-randomized studies, it was somewhat difficult to discern above background rates. It felt like that it was there, but the field remained cautious. And really, once the randomized studies came out, it was particularly when they compared against standard traditional chemoimmunotherapy, it was a clear signal in subsequent efforts to determine those patients most at risk. Sort of age and pre-existing atrial fibrillation are some of the most powerful predictors, and shown here are sort of the cumulative incidence of for those greater than or less than 80 years old, as well as those with a prior history of atrial fibrillation. I would say that atrial fibrillation is not a contraindication to initiating or continuing a BTK inhibitor, but recognizing the relative contraindication of co-administration of Coumadin and the increased bleeding risk of DOACs, this all sort of needs to be considered in the sort of risk and benefit ratio for BTK agents, whether that's ibrutinib or alternative members of the class. CTCAE for atrial fibrillation is shown here. And once again, the delineation between grade 2 and 3 is sort of the urgency of intervention, with grade 4 representing life-threatening complications. While atrial fibrillation was suspected and then confirmed on randomized studies against chemoimmunotherapy, rare cases of ventricular arrhythmias and even sudden cardiac death entered the literature. This was sort of a letter written to Blood, and you can see in the fifth column that there were isolated cases that had to be aggregated from a much larger series. But the investigators and individual patients who died of the complication, of course, these really stood out. And in some cases, these were young patients without necessarily recognized cardiac history. So this was, sort of in the under 1% category, but was pretty shocking as it sort of made its way into the literature. There have been some scientific efforts to understand the mechanism of ventricular arrhythmias, but since you guys are the cardiologists, and I'm not sure I'd understand it if I read it, I'll just point out that there are articles in the field addressing this, and it may have to do with some of the calcium repolarization or calcium flux within the myocytes, or delayed action potential, so forth. But it's not a QT prolonging drug, but these ventricular arrhythmias are really probably an on-target effect of some of these. So finally, it's important to note that ibrutinib is metabolized by the CYP3A4 pathway. So a number of cardiac medications can affect or alter the level of ibrutinib, diltiazem and verapamil, amiodarone in particular. And then, of course, the bleeding, drugs that anticoagulants obviously have a similar interaction, not because of the CYP3A4, but because of the overlapping mechanisms of action. So as acalabrutinib data continued to evolve, our group looked at 762 patients from several trials to look at atrial arrhythmias. And since ibrutinib appeared to level off around, say, 15 to 20%, we were pleased that the atrial arrhythmias with acalabrutinib seemed considerably lower, but this was in the non-comparative setting. And really, the proof came from the head-to-head study. This is from the ibrutinib versus acalabrutinib study. And on the left is the cumulative incidence of atrial fibrillation. and on the right is cumulative worsening of hypertension. And this was really, I think, the first clear indication that some of these BTK inhibitors could differentiate themselves with regards to cardiac toxicity. Breaking it down by age and prior therapy with acalabrutinib in red and ibrutinib in blue, the benefits were consistently in favor of acalabrutinib for both atrial arrhythmias and hypertension. This figure comes from the Alpine study, which was the zanubrutinib versus ibrutinib study. So the second head-to-head comparison involving zanubrutinib. And in panel B, which is the sort of top left of the four, you see a similar reduction in the cumulative incidence of atrial fibrillation. So both the second generation BTK inhibitors seem to have lower frequencies of atrial fibrillation relative to ibrutinib. But in the bottom right is actually the hypertension. And interestingly, the hypertension of zanubrutinib and ibrutinib are relatively similar. And that's actually been seen in two different studies, one in Waldenstrom's macroglobulinemia. And so, zanubrutinib may have less atrial fibrillation, but the hypertension still needs to be carefully monitored. And vis-a-vis the prior comment of hypertension being the greatest predictor of atrial fibrillation, I certainly don't dispute that in any way, shape, or form. But this data shows, sort of a protective effect on the atrial fibrillation, but less of an impact on the hypertension. So it's sort of an interesting paradox there, if you will. But to the comment made earlier, here's a screenshot from the NCCN guidance pathways, and you see in the preferred regimens on the left, there's generally a preference for the second generation BTK inhibitors. That's either acalabrutinib or zanubrutinib. And then the other recommended regimens there in the center include the first generation ibrutinib. Now, I think there's a lot of ways to take that. I do still use ibrutinib in certain cases. I feel like the side effects in many cases are age dependent. I have no problem enrolling patients on ibrutinib studies, looking at dosing or toxicity or so forth. But what you do see is kind of a move towards the second generation BTK inhibitors, and a lot of that does have to do with the cardiac side effects. So then a paper came along that really caused a lot of commotion in the field. This was a paper out of the Ohio State group, and it was a single institution retrospective analysis with a sample size of approximately 300 patients. And through their methodology, they concluded that ventricular arrhythmias were also caused by acalabrutinib. And so for a period of time, it was thought that maybe the ventricular arrhythmias were really a class effect more than specific to ibrutinib. I saw that article in a preprint and thought to myself that the methodology was not sufficiently robust to support the conclusions. And so we undertook a analysis of ventricular arrhythmias from a different data set, which included 5 prospective clinical trials, really looking at a large number of patients, 2,000 with comparator arms and so forth. So we felt like the methodology still wasn't perfect, but that it was more robust than the Ohio State group. And overall, we had a very large sample size, nearly 2,000 patients, including prospective data, randomized data, and even head-to-head comparison data against ibrutinib. And in some cases, other agents for which ventricular arrhythmias were not associated. So it gave us a much better ability to look at this. And we looked at both sudden death and fatal ventricular arrhythmias, non-fatal ventricular arrhythmias, excluding PVCs or including PVCs, because in the Ohio State group, even just PVCs would sometimes be counted as ventricular arrhythmias, which I think maybe overstates issue. So we broke it down into rates of sudden death or fatal ventricular arrhythmia, non-fatal ventricular arrhythmias, and even benign PVCs. But we did a separate analysis excluding PVCs. And due to the sample size, rare events had very wide confidence intervals. You're talking about events that are occurring in single digits of patients in large studies. So wide confidence intervals, which I think does limit these statistical conclusions. But really, in each case, the trends appeared favorable for acalabrutinib versus the comparator, whether that was ibrutinib or whether it was chemoimmunotherapy or so forth.
Is that data published? I saw you.
It is. Yeah, that's. That was that. I think that slide came from a ASH presentation, but yeah, that paper's been published.
Wow,
and it's
really good.
Available. Yeah.
Yeah, and I would say, and Joe can certainly chime in on this point, but I would agree with what you said about the previous paper that it was probably a little bit sensationalistic, and it wasn't, as definitive in terms of ventricular arrhythmias that we would have, normally have liked. But, that's the way it was. It was published that way. But your analysis looks a little more consistent with what I would have observed.
Until next time, we remind you to treat cancer, protect hearts.